How's it going, guys? Medium difficulty question for, no, fuck that, it's pass level. Okay, for step one, hematology, TCK, FMIM, and we give you no vignette because we want you to actually know your lab values. Okay, you can't rely on the vignette as a crutch oftentimes. So let's just hop through. Hemoglobin, 60 grams per deciliter normal, should be 13 to 17.5 males, not menstruating women, 12 to 17.5 menstruating women. Bleeding time is normal, 6 minutes, should be 2 to 7 minutes. Prothrombin time normal, 14 seconds, should be 10 to 15 seconds. PTT, slightly elevated, 45 seconds, should be 25 to 40 seconds. So I know you'll have the lab values available to you on the exam, but as I said in the last clip, stop your complaining, stop your crying, take your training wheels off. So question wants to know most likely explanation for findings. Let's just hop through. Choice A, antibodies against IMTS13, wrong fucking answer. This could be a mechanism for TTP, thrombotic thrombocytopenic purpura. It's a low yield diagnosis, but you'll see it mentioned in Qbank sometimes. Okay, it's going to be difficult pentad, a fever, neurologic signs. You can get renal issues. You're going to have thrombocytopenia and schistocytosis. The combo of thrombocytopenia and schistocytosis is known as MAHA, microangiopathic hemolytic anemia. It's a lengthy discussion. Wrong fucking answer. Choice B, von Willebrand disease, wrong fucking answer. And you know it's wrong because our bleeding time is not elevated. So in von Willebrand disease, 100% of questions, bleeding time is going to be high. And only about half of questions, this is a key value point for some of you, only about 50% of the time will they give an elevated PTT, okay? But you're going to have a normal platelet count. So if you have an elevated bleeding time, but you get the 50% of the questions where the PTT is normal, the student might say, well, how do we know this is an ITP, for instance? As I just said, it's because your platelet count's normal. And also the vignette, it's going to be disparate from ITP. Okay, so von Willebrand disease is going to be, it's autosomal dominant. They can give you a girl who has a combination of one platelet problem, one clotting factor problem. Platelet problem is going to be minor cutaneous findings, petechiae, easy bruising, epistaxis. Clotting factor problem is going to be heavy menses, excessive bleeding with tooth extraction. ITP is going to be a kid, usually school age, 3 out of 4 questions. Viral infection, petechiae, nosebleeds, 1 out of 4 will be a woman 30s to 40s who's just got random bruising. If it's an elevated bleeding time, that's going to be ITP. If it's a normal bleeding time, it's going to be domestic abuse for failing medicine. Von Willebrand factor bridges glycoprotein 1b on platelets to vascular endothelium / underlying collagen. That's its primary role. So if it's deficient, then of course our bleeding time is elevated. It's only a mere secondary role, however, that it can stabilize factor VIII in plasma. That's why your PTT is only elevated in about half of vignettes. Choice B, wrong fucking answer. Choice C, impaired platelet aggregation, wrong fucking answer, refers to ITP as I just harped on, okay? So this is going to be viral infection usually, and it can be asymptomatic. But if we talk about textbook, it's going to be viral infection followed by the formation of antibodies against glycoproteins 2b, 3a on platelets, impairing platelet aggregation. Steroids followed by IVIG followed by splenectomy is the treatment. Some obscure NBME question floating around where if they do splenectomy to treat, platelet count goes back up. 6 months later, platelet count goes back down. Answer is accessory spleen. Choice C, wrong fucking answer. Choice D, inhibitor of factor VIII, correct answer. So diagnosis is hemophilia A. Hemophilia A is usually, it's X-linked recessive. Hemophilia is A and B. We're talking about deficiency of factors 8 and 9 respectively. So almost always it's going to be just mere deficiency of the clotting factor, okay, where you have an isolated increase in PTT as we have here, and it's always going to be a male because we're XR. Now, OMG, we don't have deficiency of the clotting factor. We've got antibodies against the clotting factor, which the NBME exam can write as inhibitor of factor VIII. Holy shit. Okay, now another vignette. I just gave you a vague, a nonsense absent vignette here with just lab values so we can eliminate to get there. Okay, I'll talk about vitamin K deficiency in a second. But if they were to give you, let's say, a more extended vignette, they'll tell you a male with hemophilia A has been receiving allocotes of factor VIII for treatment. And now he presents with a PTT of 120 seconds, super elevated, and they just want to know like what to check for, and the answer is inhibitor of factor VIII. So you can develop antibodies against factor VIII over time when factor VIII is used to treat. Okay, so it's a mechanism you have to be aware of. Even if you've never heard of that before, you say that's very obscure. Well, we can eliminate to get there. We eliminated the first three. So let's look at vitamin K deficiency, a wrong fucking answer, because you'd have an increase in PT and PTT together, and you'd have a normal bleeding time. Okay, so vitamin K is going to be required as a cofactor for gamma glutamyl carboxylase for the carboxylation activation of clotting factors 2, 7, 9, 10, as well as anti-clotting proteins CNS. So the three main vignettes will be a neonate with bleeding from the umbilical stump, vitamin K deficiency. It can be an adult who's been receiving IV antibiotics, e.g. for endocarditis, for 6+ weeks, where you've killed off normal flora in the bowel. Third vignette can be a patient who's been exposed to rat poison, holy shit, which can have a warfarin-like effect, that is, vitamin K antagonistic. Vitamin K deficiency? Wrong fucking answer. You know the deal. To make more content, let me subscribe channel. Appreciate your time. That's it.